Good morning, my name is Antonio Galleu. I'm a clinical research fellow at King's College London. And thank you for inviting me and giving me the possibility to share with you my view on one of the most pressing questions in the field of mesenchymal stromal cells. The topic of this discussion will be the factors affecting the response to mesenchymal stromal cells in acute graft-versus-host disease patients. But why this question is so important? Let me start giving you some data. In the last decade, more than 8,000 patients with acute graft-versus-host disease have been treated with more than 1,000 infusions of MSCs. And what we know is that the achievement of any kind of response is almost invariably associated with the improvement of the overall survival of these patients, despite a very poor prognosis. So knowing the factors affecting the response to MSCs is crucial not only for the stratification of the patients, but also because it boosts our ability to improve the overall survival of our GvHD patients. So far, the models proposed to predict the clinical outcome of patients treated with MSCs have come short of the supposed predictive value. Indeed, while markers of severity of GvHD like elafin, reg3 alpha, or CK18 have been demonstrated to be significantly reduced after the infusion of MSCs only in responding patients, the use of these markers is only limited for the monitoring of the response to MSCs, since such decrease can be assessed only after the use of the cells. So what we need when we need to evaluate the likelihood of response of a specific patient, we need to have one or more factors that can be evaluated before the treatment. So in this perspective, we may want to consider some of the characteristics of the patients which have been demonstrated to be associated with the response and using them as predictors. The most informative of these factors are the age and the organ involvement of the GvHD, which with the younger age and involvement of gut and skin, which have been demonstrated to be associated with a better response rate. But also the dose is quite important, since some studies have demonstrated that higher doses are associated with better responses. However, when we use the specific factors to guide our decision whether to offer or not MSCs to a specific GvHD patient, their predictive value is quite weak and not reliable. Indeed, while we can confidently offer MSCs to a pediatric GvHD patients with steroid-resistant GvHD, because in that subcategory of patients, the response rate is quite high, around 80–85%, we cannot deny MSCs in an elder patient or a patient with involvement of the liver, just because there is still an important proportion of these patients, around 40–50% of them, who will respond to the treatment and then who will benefit in terms of overall survival. So we cannot rely only on the age or the organ involvement of the GvHD. So in this perspective, what we need is another kind of approach, a mechanistic approach, which can be translated in a robust and reliable predictive assay. We believe that a major breakthrough in this field has been achieved by our group when we demonstrated that MSCs are actively induced on the apoptosis after the infusion by the cytotoxic cells of the GvHD patients. And this apoptosis is crucial for the final therapeutic activity. So based on this data, we developed a cytotoxic assay in which we measure the cytotoxic activity of the GvHD patients against the MSCs. And we found out that this assay is a reliable predictor able to discriminate between responders and non-responders. We have now extended a cohort of patients to 41 patients in which we have tested our assay, and the data that we presented in this edition of the annual meeting of the European Hematology Association demonstrated that our biomarker is able to predict the clinical outcome with a sensitivity of 92% and a specificity of 89%. But then also we use this biomarker to assess whether any of the drugs most commonly used for the treatment of GvHD could affect the results of this assay. And this, bearing in mind that we wanted to have a sort of idea of whether these specific drugs can affect the response to MSCs. And we found out that after treatment with methylprednisolone, the cytotoxicity of the patients significantly dropped. And then if we consider that high cytotoxicity is associated significantly with the response, these results suggest that those specific patients after methylprednisolone may have lost their ability to respond to MSCs, and then the use of methylprednisolone should be avoided at the time of MSC infusion. I would like to finish saying that this is only a small, what we discussed here is only a very quick glimpse of what we know about the factors affecting the response to MSCs. But I hope that this discussion will be helpful for your decision-making process when dealing with patients with GvHD and candidates to the MSc. I stop here and thank you for your attention.